Great. It's great to see everybody. For those of you that don't know me, my name is Frances. I'm one of the acting instructors in the Division of Nephrology. And today my talk is titled, How Long Do I Have, Doctor? So to start off, broadly speaking, sorry, let me go ahead and turn on my pointer. Broadly speaking, diagnosis, treatment, and prognosis are three fundamental pieces to the practice of clinical medicine. And my talk today will be focusing on prognosis. So prognosis, why do we care? Well, I hope to convince you that for patients with chronic illness, knowledge of prognosis can guide clinical decisions and life choices. However, prognosis can be challenging in that there is substantial uncertainty around translating population level estimates into individual estimates, and clinicians find it difficult to share such information and manage this uncertainty. This is a study that nicely illustrates that prognosis is an exercise involving uncertainty. So Blair et al. Performed a meta-analysis of 8 different studies of terminally ill patients with cancer. If you'll turn your attention to this graph to the left here, along the y-axis, we have all the studies that they included in their analysis. And then along the x-axis, they have time in days, with time 0 being time of actual death. And then all these red dots here represent clinician estimates of prognosis in the various studies. And what you can see is that in most of these studies, clinicians overestimated the prognosis by anywhere from around 10 days up to 40 days. I think the take home here really is that even in terminally ill patients who are soon approaching death, clinicians were off in their prognosis on a scale of days. And for nephrologists who are prognosticating chronic illness like kidney disease, you can expect that the prognosis would be less accurate because we are pressed in terms of months to years. So due to the uncertainty surrounding prognostication, physicians are hesitant to share prognoses with patients. And as a result, patients are unsure of how their disease will progress. This is a qualitative study by Shell et al. That nicely illustrates the previous 2 themes. So Dr. Shell and his team interviewed 11 nephrologists and 30 patients at one Southern academic center in the United States. The patients had CKD stages 3 through ESKD. And the patients and nephrologists in the study were asked questions to help illuminate how nephrologists and patients discuss and understand the trajectory of kidney disease leading to renal replacement therapy. One nephrologist was quoted as saying, I don't think we really talk about prognosis in people who we think are stable and nothing is going on. One patient was quoted as saying, they really didn't tell me what kinds of things to expect. They just told me sooner or later I would go on dialysis to purify my blood. And yet another patient was quoted as saying, the only thing they say is functioning fine, but the function of what, I don't know what comes after this. This is yet another study by Saeed et al. That illustrates, I think, similar themes of lack of patient clarity surrounding their own prognosis. So Dr. Saeed and his team administered a survey to around 450 adults on dialysis in inner city Cleveland. Notably, 67% of his study population was African American. When asked, how informed are you in regards to your medical condition and how it will change over time? Only a little over half of patients, or 53%, reported that they were somewhat to very informed about their medical condition. When asked, during the past 12 months, have you had a discussion with any of the following people about your choices concerning end-of-life care? Only 5% of patients reported that they had discussed this with their kidney doctor in the last 12 months. I think the take home here really is that very few people are talking to their kidney doctor or their doctor about their prognosis. This is the same study by Dr. Saeed and his team, but they also asked patients how important is detailed information about your medical condition, and a whopping 80% of patients reported that this was important to them. Similarly, the patients were asked, how important is it for you to be informed about your prognosis? And a similar majority of patients, around 80%, reported that it was important for them to know about their prognosis. Because there's such hesitancy to discuss prognosis with patients, there's very little agreement between nephrologist assessment of prognosis and the patient's self-perception of prognosis. And this is really nicely illustrated by a study by Dr. Wachterman and her team. So what they did was that they surveyed 62 pairs of nephrologists and their patients. And they asked these pairs what they felt that the patient's chance of survival at 1 year was. What they found was that there was no agreement between nephrologist and patient estimates on 1 year survival, with a kappa of only 0.08. They also found that patient prognoses were significantly more optimistic than that of their nephrologist. So if you'll turn your attention to this table to the right, along the x-axis, we have the nephrologist's estimate of their patient survival at 1 year, and responses are categorized into a greater than 90% chance of survival and a lesser chance of survival. Along the y-axis, we have the patient's estimate of survival at 1 year. Responses are similarly categorized into a greater than 90% chance of survival and a lesser chance of survival. And I think what's striking is that 81% of patients felt that they had a greater than 90% chance of survival at 1 year, whereas only 25% of nephrologists felt that their patient had a greater than 90% chance of survival at 1 year. Lastly, only 27% of nephrologist patient pairs agreed that the patient had a greater than 90% chance of survival at 1 year. In the same study, Dr. Wachterman and her team asked the recipients about 5-year prognosis, and the numbers show a pretty similar story. Again, patient prognoses were significantly more optimistic than that of their nephrologist, and there was no agreement between nephrologist and patient estimates on 5-year survival, with a kappa of only 0.13. So again, in this table, along the x-axis, we have the nephrologist estimate of survival at 5 years, with responses categorized into a greater than 90% chance of survival versus a smaller chance of survival. And along the y-axis, again, we have patient estimate of survival at 5 years, categorized into greater than 90% chance of survival and a lesser chance of survival at 5 years. Here we see that I think my screen is frozen, sorry. Here we see that 42% of so around 42% of patients felt that they had a greater than 90% chance of survival at 5 years, whereas only 8% of nephrologists felt that their patients had a greater than 90% chance of survival at 5 years. And lastly, only 14% of nephrologist and patient pairs agreed that their patient had a greater than 90% chance of survival at 5 years. So we tend to think about prognosis as life expectancy, but it is also broadly about illness trajectories. And transplant candidacy is tied up in understanding of prognosis. So Dr. Wachterman and her team also looked at agreement between the nephrologist and their patient about transplant candidacy. And they found that agreement was only fair with a kappa of 0.35. Patients were also significantly more likely than their nephrologist to report that they were transplant candidates. So in this table to the left, along the x-axis again, we have the nephrologist's response to the question about whether or not their patient was a transplant candidate, yes, no, or don't know. And along the y-axis, we have the patient response to the same question. Responses also categorized into yes, no, and don't know. And what we see here is that a little over half of the nephrologist and patient pairs did not agree on whether or not the patient was a transplant candidate. Lastly, in this study, Dr. Wachterman and her team found that their nephrologist reported that for 60% of patients, they would not provide any estimate of prognosis, even if their patient insisted. So to summarize what I've gone over so far, firstly, there is a fair amount of uncertainty in translating population level estimates to individual level estimates. Secondly, clinicians are frequently hesitant to communicate prognoses with their patients and unsure of how to manage this uncertainty. Thirdly, a fair number of patients want to discuss their prognosis. And then lastly, patients tend to be overly optimistic about their illness trajectory. So that brings us to one of the larger studies to date, examining the prognostic expectations of people undergoing dialysis. And it was by our very own Dr. Ann O'Hare. So Dr. O'Hare and her team approached nearly 1,600 patients at 31 dialysis facilities in Nashville, Tennessee, and Seattle, Washington. These patients were approached between April 2015 and October 2018. Patients were included if they were 21 years of age or older, sufficiently able to communicate in English, and cognitively able to provide informed consent. Overall, 993 patients were eligible and completed a survey asking how long would you guess people your age with similar health conditions usually live? Responses were categorized into less than 5 years, 5 to 10 years, greater than 10 years, and unsure. The patients were also asked other questions regarding end-of-life planning and goals of care. So these were the basic demographics of that study population. So you can see that the median age was around 63 years. Around 44% were female, 56% were male. A majority of patients were white. Only 30% of patients were Black, and only 12% of patients were of other race, which here includes Native American, Pacific Islander, Asian American, and if the patient selected other. Most of the patients in the study were non-Hispanic, whopping 96%, and around 90% of patients had at least a high school education, if not a college degree. Lastly, the median time on dialysis was around 2.3 years. What Dr. O'Hare and her team found was that, again, patient expectations of prognosis tended to be overly optimistic. If you turn your attention to this graph to the right here, along the x-axis, we have the percentage of patients dying in each interval. The dark teal bar symbolizes patients with a prognosis expectation of less than 5 years. Beige bars are patients with a prognostic expectation of 5 to 10 years. And the light blue bar is patients with a prognostic expectation of over 10 years. So in this top bar, you'll see that very few patients thought that they would die within 5 years, and most thought that they would live over 5 years, if not 10 years. You can see here that around 80% of patients thought that they would live over 5 years, and over 50% of patients thought that they would live over 10 years. And this was overly optimistic compared to survival of a prevalent population of patients on dialysis in the United States, or the USRDS, where you can see that nearly 60% of patients had died within 5 years. I think it is also important to note that the survival of transplant recipients were better than the prognostic expectations of survey recipients, with nearly 80% of patients living over 10 years. As mentioned before, patient perceptions of prognosis can influence end-of-life planning and goals of care. So for this part of their analysis, Dr. O'Hare and her team compared patients with the most optimistic self-prognoses, so patients who selected over 10 years, and compared it to a reference group of patients who thought that they would live under 5 years. And what they found was that patients with the most optimistic self-prognoses were less likely to have documented surrogates. They were less likely to have documented treatment preferences, and they were also less likely to value comfort over life prolongation. Similarly, patients with the most optimistic self-prognoses, so patients who thought that they were going to live over 10 years, were more likely to select aggressive measures of care, such as CPR and also mechanical ventilation. So that brings us to present day. We were able to follow these survey recipients through September of 2020 and link 935 of the original 993 survey recipients with USRDS data on vitals to assess the actual 2-year survival of survey recipients. In this bar graph to the right, along the x-axis, we have the prognostic expectations of the patients divided into categories of less than 2 years, 2 to 5 years, greater than 5 years, and unsure. The blue bars symbolize patients who had actually died at 2 years, and the pink bars symbolize patients who were still alive at 2 years. What we found was that overall, of the 935 patients included in the analysis, 258 or 28% of patients had died by year 2. Of the 40 patients who answered less than 2 years, 19 or 47% had died by 2 years. Of the 64 patients who answered answered questions about prognosis with the answer of 2 to 5 years, 29 or 45% of patients had died by year 2. Of the 453 patients who answered greater than 5 years, 105 or 23% had died by year 2. And then lastly, of the 378 patients who answered unsure, 105 or 28% had died by year 2. We also calculated receiver operator characteristic curves as part of our analysis. The test being whether a survey recipient felt that someone their age with similar conditions would live less than 2 years. The outcome being death at 2 years. And what we found was that 2-year prognostic expectations had a very pretty low accuracy. You can see here in this table that the receiver operating curve for the total population was only 0.52, with the confidence interval ranging from 0.50 to 0.53. We then performed subgroup analyses where participants were divided or grouped based on various demographic factors, such as age group, their gender at birth, their race, ethnicity, educational achievement, time on dialysis, and their self-rated health. And what we found was that no particular group was accurate about predicting death at 2 years, and no particular group was better than another group about predicting death at 2 years. You can see that most of the ROC curves ranged from 0.50 to about 0.54. We also performed subgroup ROC analyses where patients were grouped by their responses about end-of-life planning. For For example, participants were grouped by whether or not they had official paperwork about surrogacy, whether or not they had official paperwork documenting their treatment preferences, whether or not they had thought about stopping their dialysis, whether or not they had had a conversation about stopping dialysis treatments, whether they valued life prolongation or relief of suffering, or if they were unsure, and then whether or not they wanted CPR or mechanical ventilation. And again, we found that no particular group was accurate about predicting death at 2 years, with ROCs ranging from, again, 0.50 to 0.54. We also calculated positive predictive values and negative predictive values. So here are the positive predictive value, or the probability of dying within 2 years, given a survey response that people with a similar age and similar conditions would die within 2 years. And it was just generally low at 0.47 with a confidence interval of 0.32 to 0.64. Similarly, we calculated the negative predictive value, or the probability that the probability of not dying within 2 years, given a survey response that people with a similar age and similar conditions would not die within 2 years. And this was also low at 0.73, with the confidence interval ranging from 0.70 to 0.76. We then performed the same subgroup analyses where patients were separated by certain demographic factors, and we found that positive predictive values and negative predictive values were generally low across the board, although positive predictive values tended to be a little lower, ranging from 0.4 through 0.6, and negative predictive values ranging from 0.7 to 0.8. We did the same sort of subgroup analyses where patients were separated by their responses to questions about end-of-life planning and goals of care. And again, calculated the positive predictive value for each of these subgroups. So again, the positive predictive value here was the probability of dying within 2 years, given a survey response that people of a similar age with similar health conditions would die within 2 years. And this was low across all subgroups, ranging from the mid 0.4s to the mid 0.5s. We did the same thing for negative predictive value. So again, the negative predictive value here was the probability of not dying within 2 years, given a survey response that people of a similar age with similar health conditions would not die within 2 years. And this was also low across subgroups, ranging from around high 0.6s to mid 0.7s. So what have we learned based on actual 2-year survival of these survey recipients? So in a large cohort of patients receiving dialysis in 2 metropolitan areas, most patients on dialysis tend to have overly optimistic 2-year prognostic expectations. We learned that 2-year prognostic expectations had a low accuracy across the board. And we learned that prognostic expectation of less than 2 years had poor positive predictive values and negative predictive values across the board. Next steps would be assessing actual survival of survey recipients at 5 and 10 years. Although we don't expect these to perform any better than 2-year expectations. And we believe that our study provides rationales for studies to better understand what shapes the prognostic expectations of adults undergoing dialysis, as well as those caring for them, and also provides rationale to better understand the communication around prognosis. I would like to acknowledge my research mentor, Dr. Ann O'Hare, and my statistical mentor, Dr. David Prince, as well as the research education team, Dr. Brian Kestenbaum and Dr. Nisha Bansal, and then the education team here at UW, Dr. Carrie Payne and Dr. Sarah Struthers, in helping me create this talk and sort of grow to where I am today. And with that, I will take questions. This is a picture of my dog.
Thank you, Frances. Really, really striking results. Questions for Dr. Tian?
I have one. So thanks, Frances. I'm just curious, like this disconnect between sort of patient prognostic expectations and kind of the nephrology curmudgeon. Like, is this the same in other sort of chronic conditions? For example, like stage 3, stage 4 cancer? Is this more specific to just to us?
What I've seen in the literature is that it's most well studied in patients with cancer, and the same sort of disconnect is present in patients with cancer. It's also been studied in patients with heart failure, where the same sort of disconnect is seen between patients and their clinician. So I think based on what I've been seeing, I don't think it's specific to patients with kidney disease.
I was going to comment that I can't help seeing some crossover between your and Ari's presentation about, with the question of how do we explain uncertainty in such a sort of complex situation? You don't have to have any answers, but I'm curious about what you think about, whether nephrologists are not just kind of loath to offer prognosis, but it's also just a difficult concept to explain, and how we might do that better.
That is really weighty. My thoughts are kind of rudimentary, but I think that, part of the difficulty not only is the topic itself and communicating this uncertainty in a succinct but still thorough way, but also the constraints that physicians have on their time and clinic appointment slots. And I think that generally there isn't really any formal education during fellowship, during nephrology training, in communicating prognostication. So I think those might be some areas where we might do a little better, but again, I'm far from an expert on this topic.
No, thank you.